So hello everyone. My name is Ming. This is Ming from Melbourne University. So today in our interview, the first author program, we have our very special guest, distinguished guest, Professor Jason Yam from Chinese University of Hong Kong, CUHK. So Professor Yam has been working on myopia control for many years. And one of his major contributions is on LAM study, low concentration atropine for myopia progression, the LAM study. So welcome, Professor Yan. And
hello, Professor Hong. Hello, everybody. It's my great honor to be able to join this wonderful program. Thank you so much for the opportunity.
Fantastic. So as usual, in this interview, the first author, we will be running this program 20-30 minutes, all depends on how it goes. And then it's going to be a very informal sections just to share our idea, a little bit discussion, again, in an informal way, to try to understand the story behind your excellent paper that you published on the LAM study on 1 year's result and 2 years result in ophthalmology. So the target audience of our interview, the first author, is actually the junior doctor. We call it future leader in mainland China, and also the program will be broadcast in YouTube as well. So can I just have you to give us like a general overview of what the LAM study really talk about, and what is the major findings in the LAM study?
For the LAM study, this is the 2-year result of the LAM study. That the LAM study is a randomized control trial to compare the low concentration atropine with the placebo group for 0.05%, 0.025%, 0.01%, and the placebo group for the first year. So what we found in the first year is we demonstrate comparing to the placebo, all 3 concentration is working comparing to the placebo and follow a concentration dependent response. And in the second year, we switch over the 0.0 for the placebo group to the 0.05% group. And we also follow to 2 years time, and then we found that the concentration dependent effect remains. And this is the SE progression, and this is the SE length. And we also, in addition to the concentration dependent effect, we also found that there is an age dependent effect, meaning that for a younger age, here we can see the younger age, the poorer the response, whereas the older age, the better the response in all groups. You can also see that if this is a 0.05, this is 0.025, this is 0.01, and this is the placebo group. And in fact, you can see that for a patient, for a kid using 0.05%, in fact, at the age of 6, it is roughly similar to a kid using 0.025% at the age of 8, and similar to that of 0.01% at the age of 10, and similar to the placebo group at the age of 12. So this is what we found, the age-dependent effect. And also, we also, this is a side effect. The side effect in terms of the concentration, in addition to the efficacy, we found that 0.05%, the pupil size increase is about 0.5 millimeter increase in the mesopic pupil size, and in the photopic pupil size is roughly 1 millimeter. And the accommodation loss is roughly 2 diopter. What does 2 diopter means? 2 diopter means that usually when a child have 12 diopter at the accommodation, at the baseline, they can read around 8 centimeter. When they have lost 2 diopter, meaning that their mean is roughly 10 diopter, they can still read at 10 or 11 centimeter. It doesn't really affect their reading distance. Of course, when using 0.01%, it also follow a concentration dependent response. The side effect is very minimal compared to the placebo group for the 0.01%. And adverse effect in terms of the photochromic glasses, progressive glasses, photophobia, they are quite similar among all the groups. And this is what we found in the LAM study.
Fantastic. Can we just go back to the beginning of the study? What's your consideration when you decide the LAM study? Because when you design the LAMP study, actually, in my understanding, there's already ample evidence suggesting no-dose atropine may be a better choice for myopia control in children. Like, for example, the ATOM study in Singapore. Yeah.
Yes, when I conduct the LAMP study, we are very privileged and fortunate that you have ATOM-1 and ATOM-2 study already. A lot of work, wonderful work has been conducted by our Singapore colleague. So based on the ATOM-2 study, it aroused the interest of the low concentration atropine to the world. And they found that using 0.01%, in fact, it seems to be effective on myopia control. And it is extremely important. And one of the limitation by the ATOM-2 study at that time is because they don't have the placebo control, is number one. Number two, from our understanding, in the ATOM-2 study, they originally want to use 0.01% as a control group, comparing to 0.5% and 0.1%. So in the LAMP study, I have two hypotheses. Number one, because there's no placebo compare RCT yet to show the evidence, I believe low concentration atropine, as what we demonstrate in the ATOM-2 study, is working comparing to the placebo group. So it is a need to have a placebo compare RCT to demonstrate the efficacy, is number one. And number two, as we discussed, the 0.01% in the ATOM-2 study was originally selected as a control group. So I think there is a gap between 0.1% to 0.01%. That's why I want to evaluate, are there any better efficacy, better concentration that compare in terms of the efficacy and in terms of the side effect between 0.1% and 0.01%. Therefore, we design 0.05%, 0.025%, 0.01%, and the placebo group as an RCT to start off.
Fantastic. Why did you choose these three specific 0.01, 0.025, and 0.05? Why you don't choose like 0.08, for example, when you design the study?
We have tried ourselves for some tolerance. If 0.075 or 0.08, the side effect is similar to 0.1. So the efficacy, we don't have the data, but if we have the data, it may be even better because we understand it is concentration dependent. It may be marginally better or somehow better than 0.05% maybe because of the concentration dependent effect. But the people need to use progressive glasses. So it defeats the purpose of having the other optical treatment therapy together. So I think the 0.05% in our cohort is good in a way. They don't need progressive glasses. Not many of them complain of photophobia, and they can achieve 67% roughly the achievement in terms of a very fast progressive cohort. So I think it is still a good option. But as I mentioned, so that's for we choose 0.05%, and then you can imagine from 0.1, and then the middle is 0.025. We exactly have a ladder, concentration ladder to titrate up. We want to find which concentration is the best result.
Yeah, it makes sense. Very good thinking. The first things you want to make sure is you're really be able to make an eye drop at very precise concentration level, because like making a 0.01%, 0.025, 0.05, this is very little difference on the concentration in the eye drop. So how do you tackle this challenge?
This is one of a very major challenge that we also faced at the beginning. At that time, I was also newly joined the department, not for very long. I'm learning how to conduct a trial from my department, from my seniors. So I'm very thankful to my department and also my mentors, Professor Clement Tan and Professor Kelvin Pan, for all their support and trust me to run the trial. And because our department has been doing atropine jobs for quite some years in the previous experience, so we have some connections. So we found some manufacturer, and then finally we found the manufacturer at Taiwan that they are experienced in producing the eye drops of exact concentration. So after several discussions, and we have convinced them, and they agreed to produce the concentration that we want for us to do the clinical trial. So that's why we started this program, and the concentration that we test are all under the license. Under the Department of Health clinical trial license in Hong Kong, and we have the COA, the Certificate of Analysis, to know exactly the concentration, etc. So this is they are quite good in producing the eye drops.
Yeah, I suppose this is a tremendous effort by getting the appropriate concentration eye drop, but also have the regulatory approval in Hong Kong. Yes. Because in my understanding, running clinical trial in children can be very challenging. If we run a similar trial in Australia, for example, it can take a couple of years to have approval from the ethics body, because you're talking about using the children as a study participant to test on some hypothesis. So how long have you been gone through to get this, to have the ethics approval done in Hong Kong?
So in fact, I conceived the idea of doing this, in fact, is around 2014.
Yes.
And we started the trial in around 2015. So we need to organize various meetings and try to overcome some hurdles and try to organize all this. It takes around 2 years for all preparation work. It's really not an easy task for me, because I'm quite, in fact, I joined the faculty in 2013 and starting to learn how to conduct research. This is thankfully, this is my first randomized control trial.
Fantastic. I remember the Atropine 2 published in 2012.
Yes.
Yeah. So then after that, then you in 2014, you plan a study like this, and then you finally have all these green lights, and then to really be able to commence a study in 2016. This is tremendous amount of work. And then, but then I assume because in your study, in a randomized trial, you actually managed to enroll 400 study participants, and then you convince them to be randomly assigned to 3 different concentration, low concentration of atropine that nobody have done before. And then they have a possibility to be randomized to placebo, which is with no treatment effect at all. So I assume this is quite a challenge. When you run a study in Hong Kong like this, not just for sample size, but also the fact that you have to tell the parents that your children would be equally assigned to either one of these groups. So how do you manage all of this?
Yes, this is another big challenge to run an RCT like this. First, especially given that at that time, I'm also a bit younger, even younger. So it's a challenge. And also it is a great learning opportunity for that. So because one of the reason for difficulty in enrolling the children, although in Hong Kong, there's so many myopia children, but in our hospital, in public hospital, we don't see myopia children.
Exactly.
So we don't have the cases, or we don't have the sample on hand. No, none of the sample. And if we haven't been doing the trial, we don't have all this. Because of this randomized control trial, we started a series of public education campaign. We started press conferences. And in parallel, later on, we started Hong Kong Children Eye Study, a population-based study that we have now completed about 20,000 families for eye examination and investigation. So, and in parallel of all these, we are able to start to enroll. So the enrollment process is really long. The first half year is very, very slow. But suddenly after the parents and the kids feel it's good program, and then suddenly they rush into the program, and then the speed will become faster.
I see. Oh, that's interesting, because I assume most of the children that demand myopia control, they would normally see optometrists, right? or private pediatric ophthalmologists. I'm not sure the system in Hong Kong, but this is what's happening in Australia, for example. So
yes, they see private, and also they see they are not doing any myopia control at all at that time. It's not very, very hot topic. And especially at that time, it's not common to use atropine yet.
Exactly.
It's
In Hong Kong.
almost time. And this also gives opportunity. If, say, for example, after now, it's a few years later, everybody can access to the atropine, everybody know it's really difficult to further enroll them into what we believe is better.
Yeah.
So it's the timing. I'm thankful that the timing is appropriate and it's the right time that we can do the program.
Yes. And one more question is that because I feel like when you run the study, when you commence the study, you already plan this crossover because it didn't seem to be any gap between the phase 1 and the phase 2, the first year and the second year at all. Because normally we quite like finish first year and then you require some time, maybe getting funding or talking to parents, and then you started. So how do you manage this first year and second year? I mean, you see what I mean, the interval?
In fact, in Hong Kong, the funding is not as we are very thankful to have a lot of support, but the funding is also very limited. So when our department determined to start the program, we will start it to complete it, regardless of the funding. So that's why we plan ahead, and we find the funding to support it. And for the crossover, there's two important considerations. One is the ethical consideration, because once we proved that it is working, it is ethical concern. But the other second consideration, more like it's a logistic consideration, it is far more difficult to keep the patient that you tell them you need to be placebo group for 2 years. It's very difficult. And it would take a very long time to complete the enrollment, and a lot of dropout will be expected. So we decide to use 1 year, and also to let the parents know that we are really hoping to help all the children in the program. So in the placebo group, they will switch over in case they are really the placebo group. So the parents will understand our aim and our passion, and they are willing to support. So they are all randomized and blinded to different programs, but they will know that in a few years' time, they will enjoy the treatment benefit.
I see. So I thought in your second year protocol, you actually convert the placebo group into 0.05%, which is the highest concentration in your clinical trial. So this is not a random assign. I mean, you see what I mean? Like, but at the end of 1 year, all the placebo group would be assigned to 0.05%, if I remember correctly.
Yes.
So what can you tell us, what is your consideration about this crossover design?
There are several considerations for this, because we understand that 0.05% achieve a better or optimal efficacy and side effect balance in our cohort, in our RCT. So we want to let the parents to have benefit the best optimal concentration. That is the reason. And by using, in fact, the placebo group can also be compared with the others in future. Say, for example, we have 2 years 0.05 and 1 year washout in the same LAMP 3, and then we can compare the 1 year placebo and 2 years 0.05. It's also because at the start and at the end is they are under randomization. It's still valid to compare them, and it can also give us some more insight on how to do the analysis.
Fantastic. And what's your main like a conclusion after you run this low concentration atropine study?
We are going to hopefully to publish our LAMP phase 3 results, and I hope we can able to share more soon. But based on the 4 report that we have published so far, number 1, we found that low concentration atropine is working. Compared to the placebo group. Number 2, there is a concentration dependent response. Number 3, there is age dependent response. And number 4, in fact, there is also the atropine is working on axial length, but not that on the cornea lens power. And therefore, in another report that we published is to look into the ocular biometric. So the atropine is working majorly on the axial length elongation reduction rather than the cornea effect and anterior segment. That's for atropine can help to reduce the future myopia complication.
Yes, thank you, Jason. So in terms of your comments on atropines really controlling the axial lens elongation, there's actually some controversial findings in the ATOM study. For example, in the ATOM 2 study, they didn't really demonstrate a control on the at least statistically significant control on the axial lens elongation. And also a similar, very recently published study in the India ATOM study, they also demonstrate there's some spherical equivalent control, statistically significant spherical control, SE control, but not on the axial lens elongation. So how do you comment on this in terms of fail to demonstrate statistic significant control on axial lens in the atropine control trial?
So in terms of the axial length, number one, we found that there is discrepancy between the spherical equivalent efficacy and the axial length elongation efficacy. In one of our papers into the ocular biometric, we found that the effect is on axial length, but not on the anterior segment. And you can understand the axial length in fact contribute, because in our model we also demonstrate the SE progression consists of the axial length and also consists of the lens power, the corneal power to contribute to the spherical equivalent. So the axial length portion contribute to about 0.7 to 0.8 ratio, 80% of the SE progression. So therefore, when we control the SE progression, say for example 100%, and the SE changes is roughly 80 to 70%. That can give the reason for the differences between the SE progression and the axial length. But our paper also demonstrates the change in the corneal factor is similar across all the concentration. Therefore, the major difference changes in all the group is the axial length. And going back to the differences between our LAMP study and ATOM 2 study, and also the reasons on the axial length effect. Number one, the ATOM 2 study, from my understanding, the comparison faces some challenges because it is not at the same RCT. So it's very difficult to really compare the axial length in the 0.01% to placebo group. So the comparison is not very, is a bit difficult. And for our study, we also found that the 0.01, the axial length elongation, it didn't reach a statistical significance. For my explanation or my interpretation is because of the concentration dependent response. In 0.05%, the axial length effect is higher, and then it reached a statistical significance. In the 0.01%, it also have a difference, but the difference, because of a relatively smaller, it didn't reach the statistical significance. That's why in other studies, say for example, the ATOM J study, the Japanese study, and they also and also in the in our Professor Mingguang He group, the study also using 0.01%, comparing to the placebo group, they have reached a statistical significance.
Yeah, and it also depends on how progressive. It's your study cohort. So if it's comparing to our LAMP study, to ATOM 2 study, and also Professor Mingguang He study, and also recently the Indian ATOM study in the Indian group. In fact, I believe there are several major factors to determine the response. Number one is what we found is the age-dependent effect. I believe the age-dependent effect is extremely important. In our LAMP study, the age is about 8.5. The mean age and the is based on 8.5. Very young.
For the ATOM 2 study is 9.5. is already
1 year older
in January. So the progression rate for that is slower. And that's why the response of 0.01% will be even better in the APTOM2 study, comparing in the LAMP study. And same to the Professor Wang and He's group, their age cohort is a bit older than us. So because we have recruited a younger cohort, and that therefore the comparison of 0.01% compared to the other group will be lower of the effect. But it's because of our younger cohort, our progression rate is also faster. And we can demonstrate the differential effect or the concentration dependent effect. In the Indian APTOM study, their number one, the ethnicity is different. Number two, their progression rate is also a bit slow. Therefore, and also the age, and therefore it also explains because the faster the progression of the cohort, the treatment effect will be smaller. And the lower the progression of the cohort, the efficacy is much better. So I think this is also an important consideration when comparing different cohorts.
So this probably also partially explain why in your study you observe the treatment efficacy in terms of percentage of myopia control. In the LAMP studies, 0.05%, this treatment efficacy is equivalent to 0.01% in the Singapore ATOM study.
Yes.
So because your study cohort is more progressive and much younger, and a little bit younger than the Singapore population.
Yes. So in terms of, say, for example, because we choose a younger cohort and faster progression, if our cohort is older and slower progression, the efficacy will be even higher. Because when we do a subgroup analysis, the higher group, the older age group, the efficacy in terms of all concentration is even much better comparing to the younger age group.
So in this perspective, I would say if we can pull the data and analyze the data in the same way, I mean, like you see what I mean, like they use the same category, that would really be able to demonstrate the treatment efficacy and make all this study, the findings more comparable. Do you agree with this? Yeah.
Yes, Professor Hao, you are always the smartest person.
Thank you, Jason. Yes. So in also clinically, if you say the treatment efficacy is less or smaller for the progressive or younger children, so does it mean that if I have a patient like 8 years old, progressive, like minus one diopters per year progression, should I just start 0.05% right away because I will need more control? So
yes, one of our suggestions is what Professor Hall mentioned, is because the younger the children, they have myopia, progressive myopia, the faster they have. So we need a higher concentration in order to achieve a similar result for older children with a slower progressive myopia with a lower concentration. So and also the reason if you use atropine, you will understand the older the children, say for example in the teenage or 14 to 15, their accommodation is getting lower, and the atropine will be more disturbing to them. But for the younger children, say 4, 5, or 6, they're very tolerant to higher concentration. So it makes perfectly so the younger children should use a higher concentration because of their tolerance to the side effect, and it's much better, and it's because of their progression is much faster. But the older children, slower progressor, they should gradually tail off to a lower concentration because of their progression is much slower and the efficacy will be similar to the same, and also because they're lower tolerance to the side effect.
Yeah, it's very fantastic that you mentioned the side effect. So this is, I think this is a lot of question mark from the people in China, because where there's a low dose atropine is not a clinical practice routine yet. I mean, very few people using low dose atropine for myopia control purpose. And also in a lot of countries like even Australia and like US and Japan and Korea. So this is not that commonly practiced. So people keep asking, what is the side effect? What is the side effect if we use, for example, 0.05% atropine or 0.01% atropine? Can you just explain a little bit, like, what is your findings on side effect, and how do you define whether this side effect is tolerable, acceptable for children?
Now, the side effect, in terms of side effect, we look into several parameters. Number one is the pupil size. And we found that 0.05%, the pupil size increase is about 0.5 millimeter in the mesopic pupil size, and the photopic pupil size is about 1 millimeter. And in the internationally, some use the cutoff of pupil size increase of 3 millimeter as a cutoff for intolerable, not tolerable side effects. So it's still tolerable. When a pupil size increase in 1 millimeter, people will have some photophobia. But the photophobia demonstrate in our RCT is not a lot. Okay, so the pupil size first. In the 0.05% is 1 millimeter. In the 0.01%, it's even better. 0.01% is really no significant change comparing to the placebo. So almost minimal. Okay, so the second is the accommodation loss. Accommodation loss, why in the ATOM-1 study, that 1% side effect is a very significant loss in the accommodation, and also so in 0.5% and so in 0.1%. But 0.05% roughly accommodation loss is 2 diopter, meaning that they in the baseline in these children is roughly 12 diopter at the baseline. Losing 2 diopter, they have 10 diopter at the baseline. So roughly they can still read at about 10 to 11 centimeter. Yeah. Our advice to all the children is 30 centimeter reading distance. So they don't affect their reading distance if they keep 30 centimeter. So it is the blur near vision doesn't affect them. We also measure the vision in terms of the distant VA, near VA, it doesn't affect the vision at all. And the photophobia, another parameter we use is to use the photochromic glasses. In our RCT, our data shows that roughly 30% of them need photochromic glasses. But I have to explain a little bit here, because the photochromic glasses is not prescribed in terms of the need. We allow, in the study design, we allow the parent to choose whether they wear photochromic glasses or not. Some parents are worried of the sunlight, in terms of side effect. They choose to wear photochromic glasses regardless of whether the children have any photophobia or not. So therefore you can see in our LAMP phase 1 result, even in the placebo group, there's still roughly 30% of them choose photochromic glasses because the parents feel it is safe.
I see.
It is protective. But in terms of when the children wearing photochromic glasses, majority of them didn't feel photophobia at all. So the photophobia, it doesn't affect them if they wear photochromic glasses.
Yes. So can I understand this way, even with all these symptoms, because some children have a pupil dilation or pupil mydriasis, and also loss of accommodation that cause like very near vision. So if we prescribe for those children with symptoms, we just prescribe a photochromatic lens and also the PAL, progressive additional lens, PAL plus phototropic. So would this solve all the problem? I mean, this discomfort?
Yes, if we solve all the discomfort, even though for 0.05%, not many, then a very few, maybe 100 in 100 cases, maybe 1 to 2 cases need progressive glasses. Majority of them do not need progressive glasses. So one of the major concern is they feel a bit bright photophobia at a bright outdoor time. So the photochromatic glasses really help to relieve this symptom. No need the progressive glasses.
I see. Yes. And also a lot of clinicians worry about the systemic side effect. So after, because people think people's norm is atropine is a toxic agent. So it will cause some systemic side effect, constipation, face rash, and all these. So have you observed any of these side effects in your study participants?
No. In fact, the side effect systemically, we don't see any systemic side effect at all. So in terms of flushing, all these, it doesn't happen in very low concentration and also in older kids. So we don't see any all these side effects. They are very well tolerated in our Chinese cohort in Hong Kong.
I see. Very good. So in terms of the side effect in the different ethnic groups, do you think these side effects equally apply to other people, like for example, the Caucasian population? Because we understand there's a publication that just recently published, as what I mentioned before, India population, but then we understand India children, they're also the eye is also heavily pigmented. But then how about in Caucasian? I mean, there's very much lighter pigmentation in the eye. Would this have a different effect, or are you aware of any similar study being conducted in the Caucasian population?
I think we will soon know the more aware of all this data soon, because the publication may be coming up. For my postulation and my understanding is, first, number one, I'm saying 0.05% in our RCT in Chinese is the optimal concentration, but it may not be that to Caucasian. The reason is where the pigment is more light in Caucasian. Probably they will be more sensitive to the atropine concentration. That means that 0.05% to Chinese is very good, but to Caucasian maybe is they may feel a bit more side effect. But in terms of the efficacy, it must be even better, because in terms of the progression rate.
Yeah.
So what I believe that the LAMP study, we demonstrate there's a concentration dependent response and age dependent response. So it is, in fact, it is an individualized approach. For children, if they are Caucasian or Chinese, or their progression rate, we can titrate. We can titrate to a suitable concentration that are tolerable to the family, and that are also achieve a good efficacy, and also in terms of the age. So I think probably the Caucasian, they may need a bit lower concentration to achieve good efficacy and also minimal side effect.
Yeah, very good point. And my final question is on the mechanism. So when we observe this even high dose, low dose atropine so effective in controlling myopia progression, axial lens elongation, so what do you presume or think is a possible mechanism for this control?
I don't have the exact answer, but what we observe is in fact the atropine also working on the choroid. It can stimulate choroidal thickening and also follow a response. So it is that may also potentially, it may increase the choroidal blood flow or some choroidal response. So it is not the effect as demonstrated in the animal study is not working because of the accommodation. It's working beyond that. And so we are, I believe it is moderating the choroidal flow and choroidal defect in terms to stimulate or to increase the effects of the anti-myopia effect.
So in your study, did you collect the data for the choroidal blood flow or choroidal thickness in your study?
Yes, we have the choroidal thickness data.
Will you be able to analyze and publish this part of that part of it?
I hope that the publication will soon be released. We are still under some process of the review, and hopefully it will have. We found that there is also choroidal thickening effect for low concentration atropine, and it also follow a concentration dependent response.
Fantastic. Yes. So very good. I think that's about it. And then thank you so much, Jason, Professor Yam, for joining our first interview, the first of the program. I wish you all the best for your future pursuing for myopia control, and congratulations for the very successful LAMP study as well.
Thank you, Professor Hall, and there's so much I need to continue to learn from you. Thank you so much for the opportunity. Thank you.
Thank you. Thank you so much, Professor Yam. All good.